Hi, I'm Dr. Paul Sachs. I'm Clinical Director of the Division of Infectious Diseases at Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School. And welcome to Art Switch Strategies, Year in Review and Next Year's Trends. In this review, I'm going to review the key foundations for successfully switching your virologically suppressed patient who's on HIV treatment. I just want to emphasize that's what I'm focusing on. It's the switch strategy for people who are currently on something that is virologically successful. And I think that the essence of this is that there are going to be patients for whom a switch makes sense for a variety of reasons. It could be for medication convenience, it could be for medication safety, it could be a combination, it could be economic issues. And I think there are quite a few studies in the past year that looked at this patient population. In fact, if you look overall, there are more studies on this patient population than initiation of therapy. Now, one of the key considerations, of course, is past treatments. Of course, you're familiar with the fact that you need to know what regimens people have been on in the past, what they might have resistance to, what they might have intolerance to. And then it's also critical, since so many of our regimens are equally effective, that you understand your patient's preferences. And eliciting those patient preferences is a key part of being an expert HIV clinician in 2025 and beyond. So I'm going to structure this in two main parts. The first part is going to be the switch strategies where you're basically switching to a one pill, once daily regimen. For many years now, the dominant treatments for HIV have been a single pill option, something like bictegravir FTC-TAF, or dolutegravir lamivudine, co-formulated single pill options. And since they're all the same in terms of pill burden, one a day, and they're very similar in terms of initial toxicity, which is minimal, we're going to look and see, are there some differences that come out from these studies that will make or inform clinical practice? Now, one of the studies that got the most attention was the Paso Doble study. It was a much anticipated study looking at people with virologic suppression who had no resistance to integrase inhibitors or lamivudine or tenofovir and were on a regimen that did not contain either dolutegravir or bictegravir. So this included a variety of other regimens. It could be first-generation integrase inhibitors, could be NNRTI or boosted PI regimens. And the study was done in Spain with a primary virologic endpoint and a randomization that included a switch to bictegravir IFTC-TAF, a 3-drug regimen, or a 2-drug dolutegravir lamivudine regimen. Now, in this population, the virologic outcomes were not at all surprising. We've known for some time from the Tango and the Salsa study and from clinical practice that if there's no underlying resistance, that a switch to dolutegravir lamivudine is easily non-inferior to bictegravir FTC-TAF in maintaining viral suppression. And indeed, this study demonstrated that there was really no difference virologically between the two. And then also, if looking at a variety of metabolic factors, there really was not much difference either. What got the most attention in this study was that there was a statistically significantly greater weight gain in the bictegravir FTC-TAF arm of about 1 to 2 kilograms. By the way, both regimens experienced weight gain, and that's because, remember, some of the baseline regimens in the Paso Doble study were actually TDF-containing regimens, especially TDF with efavirenz. And we know now that that regimen suppresses weight. Now, this is actually in contrast with other studies that have looked at the dolutegravir lamivudine versus bictegravir FTC-TAF switch strategies, such as the DIAD study, which did not find a significant difference. But in that study was a little different because patients were all on bictegravir FTC-TAF at the outset. So that was the Paso Doble study. I don't know whether this has changed clinical practice much because in clinical practice, at least here in the United States, most of the patients have already been on bictegravir or dolutegravir for quite some time when the switches are being entertained. We'll see. A different study is the INSTINCT-GESITA trial, which was just published in Clinical Infectious Diseases, a very fine journal to which I am extremely biased. And this was a phase 4 open label trial done in Spain with looking at people who were already on dolutegravir-lamivudine, and here doing the opposite of the dyad study, randomizing them to stay on dolutegravir-lamivudine or switch them to bictegravir-FTC-TAF, seeing whether this would modify factors of systemic inflammation or metabolic parameters or virologic outcomes. This 2 to 3 drug strategy can in some ways be thought of as an intensification strategy of adding TAF to a background regimen of dolutegravir-lamivudine. It turns out that really there was not much difference at all in the inflammatory markers, in the immune parameters, in the virologic parameters, and there was also no difference in the weight. So it shows that intensifying a 2-drug regimen of dolutegravir-lamivudine with adding tenofovir alafenamide in the form of bictegravir-FTC-TAF really didn't have much effect in the occurrence of weight gain. So since we're talking about weight as a primary endpoint in HIV clinical trials, I do want to summarize, of course, the important ACTG 5391, or the DO-IT trial. And this was an open-label phase 4 study in people with virologic suppression who had obesity and were randomized to continue on their baseline INSTI regimen, had to be unboosted, bictegravir, dolutegravir, raltegravir, plus FTC-TAF, and we're either going to continue that, as I mentioned, or switch to doravirine plus either FTC-TAF or doravirine plus FTC-TDF or 3TC-TDF. Now, as you're aware, with a lot of the attention placed on integrase inhibitors and TAF for the concerns about weight gain, this explored whether switching to a regimen that contained neither would lead to significant weight loss. We saw the primary endpoint this year presented at the International AIDS Conference, and it did not demonstrate a significant reduction in weight by switching to the TDF, doravirine, 3TC or FTC regimen, which is the one that I had predicted we would see a significant decline in weight, but we did not. And not surprisingly, the same thing, we didn't see a significant difference for people switching to doravirine plus FTC-TAF. I think we're really dealing with a situation where the problem of weight gain in our patients with HIV is not going to be amenable to ART switches. I think that's really the take-home lesson. There's so much attention placed these days on other ways to manage obesity, such as GLP-1 agonists in particular. And I think if we were really going to look at this objectively based on the accumulated data so far, I would strongly propose that we focus less on ART switches and more on things like that. In some ways, I'm viewing the whole area in HIV as people with HIV becoming healthier and therefore joining kind of the population at large, which is suffering from an obesity epidemic. All right, changing topics a bit, I do want to highlight a study that was led by one of my colleagues, Dr. Serena Koenig, and it was a study done in the Gesgio Clinic in Haiti, looking at people on second-line regimens containing a boosted protease inhibitor plus nucleosides and having them continue that regimen or switch to bictegravir FTC-TAF. And in many ways, this is a sort of recapitulation of the 2SD study previously published looking at dolutegravir plus 2 nucleosides in the same population. And the encouraging thing is that the same excellent results were obtained in the Gesgio trial, where the switch to the bictegravir FTC-TAF was non-inferior to continuing the successful boosted PI regimen. Not only that, it was nearly significantly better. And then in addition, this study adds to that baseline knowledge because retrospectively, we were able to go back and do proviral DNA resistance testing and found that, not surprisingly, there was a high rate of nucleoside resistance in this population, because remember, they were on second-line boosted PI regimens, including many patients with 3TC or FTC resistance, that's M184V, plus a good chunk who were also had K65R, and they still maintain virologic suppression. So if you're wondering, can you switch your patients with prior nucleoside resistance who are virologically suppressed to bictegravir FTC-TAF, now we have a good clinical trial that shows that it's a safe strategy. Now, moving on to investigational drugs, I want to talk about the studies that looked at doravirine/islatravir, which is a single pill treatment option that is likely to become available very shortly. These are studies 051 and 052, and there were patients who were on baseline ART, that's 051, of a variety of sorts, and then randomized to continue it or switch to the doravirine/islatravir regimen, or patients who are on baseline bictegravir/taf randomized to continue that or switch to the doravirine/islatravir. And in both studies, the doravirine/islatravir arm maintained virologic suppression. There was a little disappointingly no benefits from a perspective of weight or metabolic parameters. This is a sort of interesting finding and confirms what I said before, that it was maybe premature of us to blame the weight problems on INSTIs and TAF, because the doravirine/islatravir arm actually contains neither. And yet the study is reassuring, because it did show that this regimen does maintain suppression. Whether this one pill a day option is going to offer any benefits over our existing one pill a day options, such as I mentioned, dolutegravir lamivudine or bictegravir/taf, remains to be seen. And then another one, which is a little more novel, this is a one pill option of lenacapavir and bictegravir. And this is an open label study for patients on complex regimens. And one thing we've learned when we looked at cohort studies that had access to large databases of people with HIV being treated in the United States right now is that there are a lot of patients receiving regimens that are kind of unusual. They probably were cobbled together before we had a full understanding of resistance, or were constructed before we had these sensational second-generation integrase inhibitors. And so people are sort of stuck on complex regimens with boosted protease inhibitors, or three drug classes, et cetera. And in that population, continuing that regimen versus switching to this bictegravir lenacapavir once daily, they both maintain viral suppression in a was non-inferior. I know that some participants in this study, who have said that the patients who have previously been taking multiple pills or experiencing side effects from the boosters, et cetera, are really delighted to have this option. Okay, that ends my first section. My first big section was switching to one pill once a day. And my next big section, of course, is going to be switching to long-acting injectable options. And here, it's worth highlighting two clinical trials, two large randomized clinical trials conducted in Africa. The first of them is the CARES trial, which was initially presented last year, but published this year in Lancet Infectious Diseases, late last year, actually, in Lancet Infectious Diseases, but update this year in CROI. The CARES trial demonstrated, not surprisingly, non-inferiority of the strategy of switching to cabotegravir or pivirine versus continued oral ART, with some patient satisfaction scores being very, very high for the long-acting injectable. So that really kind of showed that this strategy of long-acting cabotegravir or pivirine could be successful even in a setting that has potentially higher rates of transmitted NRTI resistance, no baseline genotyping done, sparse virologic sampling. So CARES is really important sort of landmark study to show that long-acting injectable in the parts of the world that are most hardest hit by the HIV epidemic, it was very successful there too. And this was followed up more recently with the Impala trial. And the Impala trial looked at a patient population, again in Africa, who had a history of poor adherence to ART, prior virologic failure, and then now were virologically suppressed. So broadened the population. And the reason why this is important is because the licensing clinical trials, if you go back to the Atlas and the FLAIR trials, or the Atlas 2M trials, they did not permit people to have any prior treatment failure when they got into those studies. And once again, in the Impala trial, the long-acting injectable was non-inferior to continued oral ART, and the patient satisfaction scores are extremely high. Patient preferences for people who have enrolled in these trials have generally been higher than for oral ART, or at least they they report a preference for the injectable to the previously taken oral ART. And one small caveat is both CARES and Impala did have about that 1% to 2% of people who experience virologic failure with some emergence of integrase resistance and NNRTI resistance. And what's happening in these studies is, since the default treatment now in Africa is TLD, or tenofovir lamivudine dolutegravir, what they have been managed with is initiation of TLD on occurrence of virologic failure despite the presence of integrase resistance. So far, the reports from that small number of patients has been favorable. I don't know that we can adapt that small experience to a larger population who may have some degree of integrase resistance. But if you think about it, the most common integrase mutation to emerge in patients who fail cabrolpivirine is the 263K mutation, and that does not cause, at least phenotypically, full resistance to dolutegravir. And then also, of course, you're still getting the activity of the tenofovir lamivudine. Two interesting studies. So now, leaving the clinical trials world, we're going to move to the real world experience. I always think it's funny to describe studies that the real world versus not real world, because it's obviously everything's the real world, at least if we're talking about human data. But anyway, what that means really is that it's clinical practice rather than a prospective clinical trial. And I want to highlight the leaders in this approach of documenting their experience. Is certainly one of the leaders has been the Ward 86 population at San Francisco General, a very challenging patient population to care for because of high rates of homelessness, high rates of substance use disorder, mental illness. And in this study, which is published in JAMA, of over 200 patients with virologic suppression, they showed a very high success rate of cabotegravir or pivirine, over 90%. Very encouragingly, there's a wonderful figure from that paper that shows the time to virologic suppression is really, really rapid. I highly recommend it. Our discussion today is about people with virologic suppression, but they also included a decent-sized population in their clinic with viremia, which is really a different topic. But nonetheless, it shows that even in a population with a lot of background challenges to treatment, that the long-acting injectable regimen of cabrolpivirine is highly successful. Additional cohort studies from Trio Health and OPERA have demonstrated similar results. One thing I want to mention is that some of the reports in cabrolpivirine in clinical practice highlight a slightly higher rate of treatment discontinuation than the clinical trials. It's not surprising. I mean, the people in clinical practice, they may decide they don't like the injections, they don't like the every 2-month visits. They're not getting the financial incentives to participate in the trial that you see in a prospective clinical trial. So in general, what these cohort studies, and there's another one from Ward 86 and one from the Owen Clinic in San Diego, which have also been leaders in initiating long-acting cabrolpivirine. What we're typically seeing is about a 10 to 20% of people who initiate long-acting cabrolpivirine will end up changing back to oral treatment, just based on preference, not based on virologic failure. The virologic failure rates have been pretty consistently in around 1% in the cohort studies, which is very similar to the clinical trials. So I'd like to move away from cabrolpivirine for now and talk about other long-acting options. The one that is sort of furthest along is the once-weekly pill of islatravir and lenacapavir, and the phase 2 data have been presented showing that once-weekly islatravir lenacapavir looks like it maintains virologic suppression similarly to a baseline regimen of bictegravir FTC-TAF. The encouraging results from that have led to the EASTLAND 1 and 2, and these are fully enrolled phase 3 clinical trials of virologically suppressed patients who either stay on their current regimen or switch to once-weekly islatravir lenacapavir. I'm really pleased that the studies are being done in 2 different ways. One, baseline NEART open label trial. And the reason why I like this kind of open label trial is because it'll help us know whether the once weekly pill offers advantages in terms of adherence, et cetera. So that's the open label trial. And then a blinded trial where everyone at baseline is in bacterial FTC TAF and then randomized to either continue that bacterial FTC TAF plus placebo of islatravir lenacapavir or switch to active islatravir lenacapavir and receive placebo of bacterial FTC TAF. Now that study can't tell us anything about the once weekly versus daily administration because, they're taking pills every day no matter what, but it will give us some important information about tolerability and safety of the once weekly approach. So that's encouraging and also will be something to watch when the phase 3 data comes out. Speaking of the islatravir approach, the other once weekly approach to using islatravir will be with an investigational non-nucleoside reverse transcriptase inhibitor called ulonivirine. And ulonivirine was tested in 3 different doses in a phase 2 dose finding study, 100 milligrams, 200 milligrams, and 400 milligrams, and then combined with islatravir at the higher dose of 20 milligrams a day once weekly versus a control of bictegravir FTC TAF. And these were patients who started with virologic suppression. The study was presented this year and demonstrated that it maintained suppression just as well as the bictegravir FTC TAF arm, enough to proceed further with the selected dose of ulonivirine. And the selected dose of ulonivirine will be the intermediate one, the 200 milligram one. And of course, the selected dose of islatravir will be the lower dose that's being used now in the EastLen trials. And we look forward to seeing further studies of sort of repeat of this dose finding study using that lower dose of islatravir. So that sums up the once weekly pill options. But what about a longer acting approach? Well, here we have to go back to injectables, and we can look at the lenacapavir subcutaneously administered every 6 months, along with 2 different monoclonal antibodies, which I'm going to call TAB and ZAB. And we have seen data before in this phase 2 trial, but this is now week 52 data of lenacapavir plus TAB and ZAB. And the baseline regimen is the comparator arm, 80 participants randomized 2-to-1 to receive the every 6 month Len plus TAB and ZAB or the continued oral baseline regimen. One thing to mention with any BNAB study, and this is kind of, in my view, a real limitation of BNABs, is that you need a baseline resistance test to show susceptibility of the BNABs. And in this trial, they actually screened 241 participants in order to enroll 80, and that's because some of the participants did not have susceptibility to both drugs, both BNABs. Some of the participants, the test did not result at all. And you can see that it's sort of a problem, but one that we hope that will be overcome either with improvements of the test or improvements in the antibodies. But nonetheless, it did demonstrate that it can maintain suppression in most of the participants in that trial. 3 participants in that study actually had virologic rebound. All 3 of the participants, not surprisingly, when they went back on bictegravir FTC TAF, they resumed virologic suppression. They did actually have a very high BMI. All 3 of them weighed more than 100 kilograms, and we know that weight is a covariate in antibody exposure, and so I suspect this was probably related to lower TAB and ZAB levels, but that could not be fully explored with such small numbers. Nonetheless, this is exciting to hear about an every 6 month ART strategy. And, I know my patients, when they heard about lenacapavir for PrEP, they said, what about every 6 month treatment? I think it is possible, but I would say that the ideal partner for lenacapavir still is to be determined. And the last study I want to mention is another longer-acting BNAb study. It looks at VRC07523LS, administered with cabotegravir once monthly. It was a study of 74 participants in an open-label trial. There was a 7% virologic failure in this trial, despite the fact that the participants had to screen susceptible again to the VRC07523LS. One of the participants, unfortunately, did develop the R263K integrase mutation. This is the one I mentioned before with cabotegravir. So because they're receiving cabotegravir plus the BNAb, but for whatever reason, the BNAb wasn't active enough, so they were essentially receiving cabotegravir monotherapy. So the conclusion of this study was that the strategy of cabotegravir once monthly plus VRC07523LS maintained virologic suppression in 93% of the participants, and was pretty well tolerated. But the fact that 7% of the participants experienced virologic failure is frankly too high. What this shows is that the bar now is set, the very high standard for patients who are already virologically suppressed. Even though I mentioned that some patients on captopril will actually decide to come off it, they're not coming off it generally for virologic failure. The success rate of the on-treatment virologic success rate of captopril is 98 to 99%. It's not 93%, and especially when the resistance consequences are high, like they would be with development of integrase resistance. So there were a lot of things that are exciting to look forward to. I think most of them are going to be involved with longer acting preparations. The days where a new one pill once daily treatment is really going to offer us anything novel are probably over, because we have such good one pill once daily options. So long-acting injectables or long-acting oral options for HIV therapy are really what we're looking forward to for the coming future. So I want to thank you for joining us for this ART Switch Strategies Year in Review and Next Year's Trends. Please click Continue to complete a brief post-test and evaluation to claim your continuing education credit. Take care.